Okay, so good evening, ladies and gentlemen. Welcome back to the YouTube channel. I'm delighted this evening to be joined by Dr. Gwen Evans, who has just finished her post as a junior clinical fellow in neurosurgery at King's College Hospital in London. Thank you, Gwen, for coming and speaking to us.
Hey Ollie, yeah, thanks so much for having me. It's a pleasure.
Before we move on, we discussed this beforehand. I decided I wasn't going to butcher your name kind of on air. Could you please give us your full name with the proper pronunciation?
Yeah, so I have a Welsh name, which means it's not pronounced how it's written down. The proper way to pronounce it is Dr. Gwenllian Evans. That's why I just go by Gwen. It's much easier.
Okay, just in the interests of getting you the proper professional recognition you deserve. I think the plan for this conversation, I had a lot of questions about what exactly a clinical fellow is and what a junior clinical fellow is. So there's that to address. I think obviously your path through medical school and your steps you've taken to get where you are. And then I suppose the process of applying for neurosurgery. So you're the first authority therein that we've had
Oh, okay.
to
No
speak
pressure.
to. But we'll see how we go. So do you just want to give us a quick summary of kind of what you've been doing for the last year, what your role involved?
Yeah, so as you said, I was a junior clinical fellow in neurosurgery at King's for the last 9 months. And what a junior clinical fellow is basically somebody who is not in a training program, but at an SHO level. So you're not in your foundation years and you're not on a training program, but you're being treated as an SHO for that job. So my role involved dealing with patients on the ward, clerking in new patients when I was on call. I got to go to theatre and assist in surgery, which was really cool. And basically just being a neurosurgery SHO, but without being on the actual training program.
Cool. So as you know, we try and keep things friendly for the boys and girls at home who may not know the technical terms. So an SHO
Mm-hmm.
for the
So,
people at home. What's an SHO?
so an SHO stands for Senior House Officer. It's actually an outdated term. People don't really like using it anymore, but it's persisted. But a Senior House Officer is somebody who is at least 2 years out of medical school. So in the UK, you finish medical school. Your first year out of medical school, you're a FY1 or a Foundation Year 1 doctor. After FY1, your provisional GMC registration becomes a full registration, so kind of like a driving license. And once you've been fully registered, after that, you are an SHO for a couple of years. And then when you get to about 3 years into your specialty training, you become a registrar. So you can actually be an SHO for about 5 years and still be an SHO, but different levels of an SHO. Does that make sense?
Yeah, great. And then someone actually messaged me in to ask specifically about this. It's a natural point to bring it up. You talked about a training program,
Mm-hmm.
and you're being employed as an SHO in neurosurgery specifically, but not as part of a training program. So why might someone why does that post exist? Why might someone want to do that?
So for me personally, in terms of the UK structure for getting onto training programs, you have F1 and F2, and then about 3 months into your F2 is when you make an application for the training program, and that training program, if you get onto it, is for neurosurgery. It's about 8 years long. But I always knew that I wanted to take a break after my F2 to get some more experience in neurosurgery because I'd never had a neurosurgical job before. And that's why posts like this exist. It's for exactly those kind of people who might not have had a neurosurgery job in F1 or F2 and wanted to get a bit more experience, either to decide, yes, I want to do this, no, I don't want to do this, or to bolster their application to neurosurgery. And it's a really, really good way of just seeing whether or not that is the job for you, because it's basically like a no commitment thing. You do it, you enjoy it, then
Yeah.
great. You do it, you don't enjoy it, your contract finishes, you don't have to do it again.
So is it the job for you?
Oh, absolutely, yeah. I've known it's the job for me since I was 6. So Yeah.
Why not? I mean, that sounds like a really good idea. And to keep things again clear for anyone who is wondering about the way the jobs work, that this is something that I'm acutely thinking of myself, because in what month are we in? End of July. In several months, I'll be applying for my foundation jobs, which is terrifying. But to keep things clear at home, you rotate through 6 jobs, 4-month stretches at a time, which can be across a range of specialties. So, in fact, just very briefly, could you tell us what your jobs were? Just it might be of interest.
Yeah, of course. Yeah. So I did both my F1 and F2 jobs at the same hospital. So not only do you rotate jobs, but sometimes depending on where you got placed and which job structure you've got, you can also rotate hospitals. So some people will be in one hospital in F1 and a different one in F2, or like me, where I was in the same one for both. So I did both of my foundation years at Bedford Hospital, and my FY1 jobs were general surgery, cardiology, and A&E. And then my F2 jobs, so my SHO jobs, were vascular surgery, psychiatry, and respiratory.
That's a real baptism of fire, starting on general surgery.
Oh, my word. Oh, no, that was easy.
Really?
So easy. Yeah, really, really chilled out. It was really good fun.
But
I think I'm biased because... Yeah, I think I'm biased, though, because I want to be a surgeon. So for me, starting on surgery was a blessing.
I've just heard some horror stories from people who I guess particularly don't have the aspiration for surgery. When you're expected to kind of know things and know what to do, I've heard it can be a task.
Yeah. To be honest, I think starting on medicine's harder because the medicine on calls are significantly harder than the surgery on calls. Because as a whole, the medicine on calls, your patients are sicker, whereas with surgery on calls, it's mostly just post-op complications.
Sure. Fair enough. So, sorry, something just bibbed at me. Is WhatsApp still? My WhatsApp's open, that's why. Good, so that's the jobs. So moving on from that then, it's perfectly possible then, in theory, given with run-through programs such as neurosurgery, that many of the people who wish to apply for it will never have had either a neurology or a neurosurgery job.
Yeah.
Is that a problem when you're applying for neurosurgery?
No, not at all. In fact, when you're applying for neurosurgery, outside of FY2, you are not allowed to apply for neurosurgery if you've had more than a year's worth of experience in either neurology, neurosurgery, neurocritical care, or ITU. So they actually don't want you to be overqualified. Obviously, it will help in terms of interview if you have had neurosurgery experience, because the neurosurgery interview is very, very unique in that they expect you to have some knowledge of clinical scenarios with neurosurgery, and having had that experience in real life will really, really help you with all the different stations and how to answer it, for example. So in that respect, yes, it is helpful to have a job, but it's not impossible. And I do know some people that have got onto the training program without ever had any experience in neurosurgery. You can just make up the strength of your application in different ways.
Sure. So let's go back to the beginning then. Before the chat about all this, so I realise we're slightly out of chronological order here, but because you mentioned having wanted to do it for a long time. So young Gwen, she decides she's going to be a brain surgeon.
Yes, little 6-year-old Gwen.
So you're doing your A-levels. You're applying for, well, let's go back to GCSEs, in fact, because that's, I guess, when you have to start thinking about medicine. Were you thinking about medicine at the time?
Yeah, I was thinking about it since I was 6. It was always, like literally always, neurosurgery, medicine, always like that. Granted, when I was 6, I did say to my mom I want to be a neurosurgeon, and in my spare time, I would also like to be a ballerina and a policeman and a vet and a farmer. but neurosurgeon is the one that stuck. But yeah, GCSEs, I was always thinking about medicine, so I had to arrange volunteering and work experience opportunities, which, as I'm sure a lot of your watchers are aware, there's a lot of different things that you need to be able to get accepted for an interview for a medical school place. So I tried to get onto that a bit early, but because I had skipped a year and I wasn't 16, I was not allowed to do a lot of work experience in this country, unfortunately.
Yeah.
So that was quite difficult, that element of it. But I did well on my GCSEs, so still good.
It's from what you were telling me before, you absolutely demolished your GCSEs by the sound.
Yeah.
Tell the boys and girls what you got. Go on.
So I was a real disappointment to my Chinese mother. I got 10 A stars and 4 A's. And
The horror.
Went home being I went home, I was really excited. And my mom was like, why didn't you get 14 A stars? Who did I raise you to be? but yeah, I got 10 A stars and 4 A's. So.
Honestly, like, why bother? Why bother? So
can't show my face in the house ever again.
I know.
That's why I'm in London.
Presumably that eased off once you became a doctor a little bit.
No.
Never lived it.
Should I tell you the story of when I got my first? Sure,
let's go.
So, I intercalated in neurosurgery. I wish. I intercalated in neuroscience, and I had a significant life event that led me to taking a year out, and then I came back, and I finished my intercalated degree, and I managed to get a first, which, during my workup for this, I was like, you know what? After everything I've been through, I'm happy to just get a 2-1. But I got a first, so I was like, oh my gosh, this is amazing. So I called up my mom and I was like, Mom, I got a first in neuroscience. And she went, okay, how good of a first? I was like, well, a first is a first.
Yeah.
She was like, how good of a first? What was your first compared to? And then she named like one of my colleagues. And I was like, okay, I got a 71. Okay. And what did your friend get? He got a 73. And then she was like, well, I suppose a first is a first. I was like,
oh my God.
Yeah.
But it's the
Chinese
way,
moms.
isn't it?
Yeah.
So moving on then. So you one of the things we were talking about beforehand, which I think would be really useful, was the A-level component. Because this, from what you told me, was a bit of a departure.
Yeah, it was. So as I'm sure all of your viewers are aware, getting into medicine is obviously very, very competitive, and they always ask you for the best grades possible. And I was the first year in my cohort for sixth form to get the A stars. So we were basically the guinea pigs for A stars. So I went through sixth form and I was predicted to have 3 A stars, which was great. So all of my university choices gave me an offer for 3 A's. But then something happened in sixth form and I actually missed my grades and I got ABB. So that was obviously a bit of a shock. But I actually logged on to UCAS, which is the university application website. And I logged on to UCAS at 6 a.m. on results day and I saw, congratulations, you're going to go study medicine at King's College London. I was like, oh, this is amazing. So I went to school expecting to see at least 3 A's or maybe 3 A stars. And then I read this paper and it's like ABB. And I'm just double checking my name and the grades. And it's like, oh my gosh, what's going on?
Yeah.
And all of my teachers were saying, are you okay? Have you gone through clearing? Do you need any help? And it's like, no, actually King's just accepted me, even though I missed 2 of my grades.
Yeah.
And I think that's because I had quite a strong personal statement and I interviewed really well. And I had a good UKCAT. But yeah, like grades are one component of your medical school application and they are part of the things that get you invited for interview, but it's not the be all and end all because, you also want your doctor to be a human and not just be a textbook.
Sure.
Which is why I always think the interview is really, really important.
Definitely. I think that's a really important lesson. So anyone listening at home or either watching the video or listening to the podcast form of this, if you take nothing else away, I would take away that lesson from this talk, because there are some things I think that the medical selection system does not do very well, just because of the way it's set up, and there are increasing efforts to make more rounded doctors that patients like to interact with better, because that's a huge part of care as well, is that interaction and delivery. So you got your A-levels.
Yeah, I mean,
sorry, go on.
Yeah, sorry, just to interject with that, like just to add to your point, I mean, it's all well and good if you know the, I don't know, 20 different causes of abdominal pain, but if your patient can't tell you they have abdominal pain, they can't tell you the nature of it because they don't trust you or they don't want to talk to you, then what's the point?
Yeah.
So anyway.
Yeah, no, it's that you've got zero to work with, haven't you, in that situation?
Yeah.
So
anyway,
you got your grades. So then we kind of go through university, you do your intercalation. We talked about intercalating with Bran on the last episode of this that I did. So if you want a more in-depth coverage of intercalation, I'd recommend going back and watching that video. I won't ask Gwen to recap it, but I think it's, if you're willing, we could probably talk about your own neurosurgical I was going to say experience, calamity.
It was an experience. Yeah, absolutely. So I was halfway through my intercalation into neuroscience. I had finished all of my modules, and it was the last day of my lab placement, and all I had left was my dissertation and my exams. And then out of nowhere, I ended up having a stroke, a hemorrhagic stroke, also known as a subarachnoid hemorrhage. So I was 21 at the time. It turns out I have this thing in my head called an AVM, which is an arteriovenous malformation, which is like this big tangle of blood vessels in my brain that shouldn't really exist. And I became a neurosurgical patient myself, which was quite ironic because I'd always wanted to do neurosurgery since I was a little girl. So that was a very interesting experience, and it was quite eye-opening to see life from the other side, because as a medical student, I'd already had a year of clinical experience at that point. So actually I self-diagnosed and tried very, very hard for people to get me a scan, but because I was 21 and it was a Saturday evening, they thought I was drunk. So I was like, please just get me a scan. But anyway, but from being a clinical student, all I saw was just patients. I constantly just saw patients the whole day. So I always thought as a patient that I'd always be able to see the doctors the whole day. And I was really, really surprised to find when I was on the other side that you only see the doctor for like 5 minutes and then that's it. The rest of the day, you don't see the doctors or you see other nurses. And, it was really eye-opening to really understand that actually our patient interaction is very, very minimal. Even though it feels like it's not, to the patient, it's extremely minimal. And actually the nurses are amazing.
Yeah.
The nurses are the true heroes in all of this. So that happened. I had to take a year out of uni, much to my behest. Did not like that. And I had to come back a year later because my stroke had left me without memory of the 3 or so months before and after, which meant it completely erased my memory of my BSc. So I had to teach myself my degree again.
Wow.
Yeah, I had to teach myself my degree again. I had to finish writing my dissertation and I had to write my exams. But my stroke left me with epilepsy and some cognitive difficulties. So I had to go through rigorous neuropsychological testing, cognitive testing, psychiatric counseling, therapy, you name it, because it affected me quite significantly. I had to go through the whole process of applying for special circumstances, writing all the letters to the university, explaining why I needed certain special circumstances, the whole shebang. But after teaching myself my BSc again, I got a first, which my mother was disappointed with because it wasn't as good as...
absolutely incredible.
So that's a little hiccup in my medical story.
Neurosurgical.
But I've written a blog on it. Yeah.
We will link that in the description.
Yeah,
please.
because I thought I have still have one of the most unique experiences as a future, well, aspiring neurosurgeon.
Sure.
And I thought I really just want to take that experience, and even though it was awful, I wanted to make me a better doctor. And because I was bored out of my mind, I just kept writing like random reflections on my life. So I kept a blog, and I feel like it gives you a really unique look into being on both sides.
Very good. And I mean, that's, I say, we'll make sure that's linked in the description below. And I'd really like to, just again, bearing in mind that the slant of this audience tends to be towards either younger medics or those thinking about applying to medicine. Personally, I feel that it's one of the great miscommunications that happens when it comes to applying for medicine, in terms of how much of a caring role doctors actually have, which is actually very minimal. As you say, you realise if you've been a patient, or even as a clinical medical student, obviously, as you said, you're seeing patients all day, every day, but you're not seeing each of them for very long at all. And this is something that I'm quite keen to impress upon the people when I mock interview them, or I'm chatting with them about applications for medicine. I would not emphasize the caring role of the doctor if I were trying to give an indication that I understood the career, because it's just not accurate. At least relative, if that's your motivation, is to care for patients, probably do something else, I think would be reasonable.
I know certainly with my cohort, when we were doing mock interviews for medicine, if you dare said the words, I want to be a doctor because I want to care for people, the mock interviewer would say, well, why don't you be a nurse, or, a care home worker, or a social worker, because they all care for people. Yeah.
And they do it far more than a doctor ever, I would say, would or could, and they do it,
The nurses, shout out to the nurses.
The nurses are your best friends as a patient or as a medical student.
And as a doctor. Absolutely.
Okay, so you successfully retaught yourself neuroscience. You did very well. We've spoken about your jobs that you did as a junior, and your experience doing this clinical fellowship job, and the goal is now to become a neurosurgeon.
Correct.
Or remains, I suppose, to become a neurosurgeon. So I feel like, given that you're the authority on this that we can have on the channel, let's talk about neurosurgery specifically. Why, you've had this attraction even before you had any inkling, I suppose, that you would be a neurosurgical patient. Yourself, why neurosurgery specifically?
So that is a question that's definitely going to come up in interview. Should I tell you the story of why little 6-year-old me decided to be a neurosurgeon?
Let's have it, sure.
Okay, so my mom had bought me this little cardboard cutout book of the human body and all the different layers. So you turn the page and it would be the skin, and then you turn the page and it would be the muscles and the bones, etc. So I read this, and at the end I thought, wow, this is amazing. I really want to be a doctor because the human body is amazing. But I like working with my hands, so I have to be a surgeon.
Yeah.
But I only want to be a surgeon of the things that are most important in the body. So that's either the heart or the brain. But the brain is really cool. Okay, I'm going to be a neurosurgeon. So that was my thought process.
Nice.
And I've refined it a bit more. Like, I still really enjoy working with my hands, and I really enjoy the fine element of neurosurgery. You not only get to do like macroscopic kind of surgeries, big open surgeries, you also get to have the microscopic things where, it's really, really fine motor skills. And I play a lot of video games as well. So it's like, it's marrying all of that together. But also I love the anatomy of the brain. I love the fact that the brain there's still so much that we don't know about it. And it's really exciting, the fact that we still have so much more to learn. And it's also a real honor to be given the privilege of being able to work with something that holds somebody's memories, somebody's personality, somebody's life, all in that tiny little thing. The brain is just amazing. So I don't know. I'm a bit of a fangirl about brains.
Why not? Those are the people surely that we'd want to be our neurosurgeons.
Yeah. And the surgery is just, it's really intricate and it's really beautiful.
I think that's a really nice explanation, and very, very honest, I would say as well. I think that's when I ask people, and when I'm thinking myself about why we want to do the things we want to do, and certainly I share the same feeling of I didn't have the cardboard cutout book with a brain and stuff, but certainly thinking I'm going to be a doctor, but I like working with my hands too much, therefore I have to be a surgeon, or something procedural. We're seeing radiology and other disciplines are increasingly doing this motor skill based procedural stuff, but none of it quite competes with surgery just yet, I think. Have you had any thoughts, because neurosurgery, almost thought then when you're saying I need to be a surgeon of either the heart or the brain, setting yourself up for the most competitive specialties perhaps in all of medicine.
Clearly it's just my Asian upbringing, so
maybe. Have you had any thoughts? I hesitate to ask, is there a plan B, but have you had any thoughts?
Originally there was no plan B. Originally it was like neurosurgery or bust. But obviously, as you go through med school, as you go through life, you do realize that you do have to be open to a lot of different things. And my goal is still very much neurosurgery. But I actually found myself enjoying my cardiology job at F1 a lot more than I thought I would.
Yeah.
And cardiology has practical aspects of it. You can do stenting, you can do pacemaker insertions, things like that. So maybe not my plan B, maybe my plan like Z, because I'm going to keep trying until it gets there.
Sure.
But if anything stops me from becoming a neurosurgeon, then maybe cardiology. But I also enjoyed my vascular job more than I thought I would. So if I'm still able to do surgery, then probably vascular surgery. If I can't do surgery, then cardiology.
Amazing. I mean, I say again, you're picking these very like type A specialties, aren't you? For those who don't know, I think all of the specialties that Gwen just listed must be in the top like 10 for competitiveness ratios. Because
Tiger Mom.
Well, it's again something that certainly my parents, when I'm discussing how medical jobs and things work, I feel like people who aren't in the medical sphere, the job structure and processes are not well understood. People just sort of think that you go to medical school, you become a doctor, and then you decide what kind of doctor you're going to be, and then that's kind of that. In the reality of it, there are at every stage. So while you're a medical student, while you're a young doctor, even I guess on your way to being a consultant with your fellowship things, there are exams and processes and hurdles all the way through. And in many ways, you are very much not guaranteed the job or the lifestyle or even the location in which you work that you think you would like or you would benefit from. And you do have to compromise sometimes. More often than not, you do have to compromise. And I've often, had the thought, because neurosurgery is very, very competitive. Just some fun facts for your viewers out there. Please,
in this round of selection process, there were 21 neurosurgery training jobs. And that's across the whole of the United Kingdom, so England, Wales, Scotland, and Northern Ireland. 21 jobs, that's it. And about 300 or so applicants. So, very, very competitive. And I did always think, if I get a training post and it's like Scotland, would I go there? No offense to anyone who's Scottish, I just cannot tolerate the cold.
I thought you say I can't tolerate the Scots.
No, the Scots are great. I just can't tolerate the cold. But actually, yes, if I got a job and it took me to some far-flung reach in Scotland or Northern Ireland, yes, I would I would go there. I'd relocate because that's my compromise for doing what I want to do.
Yeah, and again, just particularly applicants out there, younger medical students, these training posts, the number of them, there are a limited number for every specialty, because, as you say, it's not just I want to be a cardiologist, therefore I will train as a cardiologist. The government wants a specific number of people to train as cardiologists every year, or the NHS, I suppose, as an extension of the government in response to the patient load that those specialties need or want. So while we need very many GPs, maybe more than any other specialty, we need psychiatrists at an alarming rate. We need emergency medicine doctors, we need oncologists, we need lots of these things. What we don't need lots of, unfortunately, are neurosurgeons, because the problems are so niche.
No, but also there are very, very few neurosurgical centres in the UK.
Yeah.
So just in terms of an infrastructure point of view, there's only so many places that can actually offer neurosurgery.
Yeah.
Whereas everybody needs a GP. Shout out to GPs, you guys are great.
Yeah,
also,
it is true.
Holly, can I please say a pet peeve of mine that I just want to clear up? You can cut this if you want to, but
sure.
One of my biggest pet peeves is people that think as soon as you've qualified for med school, you're a GP. You are not. After med school, you have to do 2 years of foundation, and then it's 5 years to train to be a GP. It is hard being a GP. Like, you are not a GP as soon as you leave med school. Give them more respect.
Yes, GP, this isn't appreciated, but GPs are specialist doctors. GP, or general practice, is a specialty. It's a medical specialty. It's the shortest training pathway, but they are specialists whose specialism is general medicine, right? As perverse or paradoxical as that sounds.
Yeah.
In almost, I guess, the way that I conceive of GPs is I split kind of general medicine into community, so general practice, and emergency medicine, or acute medicine, I guess, as you have in your hospital. And GPs need as much medical knowledge, if not more, to draw on than, as any other type of doctor, because literally anything, if Gwen is on her neurosurgical unit, the odds are good that whatever patient comes onto the ward likely has a neurological or a neurosurgical problem, which dramatically rounds down, I guess, not the cognitive load of what you're doing, because it's very complicated, but you have a rough idea of what the problem is, right? Whereas you're a general practitioner, maybe the only one sat there that day. Someone could come into your room having a heart attack, someone could be having a stroke.
You only have 10 minutes to see them.
Yeah. So that's, honestly, I'm not going to cut that, I'm going to leave it in. That's very, very important.
Yeah.
That people see GPs that way. So I think something that I'm going to ask you one more of my own questions. I'm being very selfish, but we did get sent some in from the audience on very good notice, I should say, because I only promoted this last night.
Yeah.
So the last question I have is about women in surgery.
Oh, okay.
I know it's a bit of it's a meaty topic, but I think it's something that's really important, and we've not really been in a position to discuss it with a woman in surgery as such on the channel before. So I guess just to break into this, can we tackle women in surgery as a whole? What's been your experience? Why do these issues around women in surgery persist, in your view? And then specifically neurosurgery, because different specialties have different reputations for this. So let's start generally. As a woman in surgery, how have you been finding things?
So even before if you don't mind, I'm going to go back to
Please.
women in medicine and then build on that, because even before becoming a woman in surgery, being a woman in medicine, it's quite difficult. Like, there's a lot of inherent biases that until they're pointed out, people don't realize are there. And it goes both ways. But, you know, I have a lot of stories from when I was a F1, F2 doctor. So I was a fully qualified doctor. And I was seeing patients in A&E, making management plans, you know, being a doctor. And I would examine my patient and, you know, be very, very thorough with them, explain everything to them in great detail. And then they'd say, "Oh, thank you, lovely. But when am I going to see the doctor?" And I'm like, I'm wearing a lanyard that says doctor. I've introduced myself to you as the doctor. I'm wearing a badge that says doctor. I am your doctor. Please believe me. But, you know, there's a lot of inherent biases. And I know I look young, but, you know, I've introduced myself as a doctor. And then there was another occasion where I did some bedside teaching with some medical students. Bedside teaching is where you take students with you to the patient's bedside. You ask them to examine them or to do a history, and then you give them some teaching about the patient's condition or whatever signs they found. So I took some students for some bedside teaching. This is a patient I'd met on the ward round where I was introduced as a junior doctor on their team. I then reintroduced myself. "Hi, my name's Dr. Evans. I'm one of the doctors that you met this morning. I have these medical students. Can they please examine you?" "Oh, yes, of course, yes, sure." So at the end of it, she goes, "Oh, well, thank you very much, dear. When are you going to be a real doctor?" And then she looks at the male medical student and, "Thank you very much. Are you the consultant?" And I'm like,
oh. Yeah.
Yeah. So that's women in medicine as a as a baseline.
Yeah.
And then it gets worse.
It only goes downhill from here.
Yeah, and unfortunately, you have probably picked the worst person to talk to about this, because I've actually done a project on this and have presented it nationally, and and I'm about to write it up. But yeah, so my experience of it, my first day in my foundation job at my hospital, they were showing me the ropes. They were showing me how to do interdepartmental referrals. So say, for example, the surgeons want to refer to the medics. The way to do it at my hospital is on this paper form. It's just this paper template. And this is the first thing. Bear in mind, I'm a young, impressionable, newly qualified, fresh out of med school graduate. This is the first thing I see. And it's this paper template, and it says, "Dr/Mr. blank would like to refer to Dr/Mr. blank."
Yeah.
And I'm there like, I want to be a surgeon, so do I cross this out and write Miss? Like, what do I do? Because I'm neither a doctor nor a mister when I'm a surgeon. So I picked up on that and I created a project out of that. And it was really, really interesting to see people's reactions. And this is why I talked about an inherent bias, because the amount of times I handed this piece of paper to somebody else, even women, and I said, "What is wrong with this?" They'd be like, "No, there's nothing wrong." And then I point out the Dr/Mr. and they're like, oh yeah, "Oh, I never noticed that. That's awful." And I'm like, exactly. That's just this inherent bias. But basically, what I found was actually the amount of female surgical trainees is now greater than the amount of male surgical trainees. So if you look at the Royal College of Surgeons' latest figures, there are about 65% female trainees compared to 35% male trainees. But when you look at the consultants, something happens on the way to becoming a consultant, and there are significantly more male consultants than female consultants. And what we found was, even though there are no barriers, no major barriers to entering surgical training, it was the retention in surgical training that was the main issue. And in the study that I did, we basically asked lots of male and female doctors and medical students, all from any background, surgeons or non-surgeons, what they perceived to be the barriers. And basically everybody said it's because it's still very much a man's world. You know, it's a very alpha male dominated field, and a lot of women feel like they have to sort of become join the old boys club. to
Yeah,
become a
yeah.
surgeon. And I'm sure this is going to get a lot of backlash on Twitter or YouTube or Instagram or whatever. But
We
my
do love a bit
personal
of drama.
experience, yeah. But my personal experience is, yeah, I have basically had to be a bit more assertive, otherwise people don't take me seriously. And the amount of times I've had to explain myself and stand my ground because I was, well, my perception was it was because I was female. You know, it's a lot more effort and a lot more microaggressions than my male colleagues get. So yeah, that's. Sorry, I went on to a bit of a rant.
No, but it's not a rant, is it? It's an evidence, but you've done a study on it. It's an evidence-based discussion, and
I'm pleased to say that hospital has changed their referral form, or at least said they would after I presented it, and it created a Twitter beef.
So was that a quip technically? The fact that
no, it was a quip.
Yeah.
No, it was a quip. I designed it as a quip.
Great, good. Quality improvement project for those at home. They're really important.
Yeah.
So, I guess a follow-on question that before neurosurgery specifically is that if we, so you're saying that the distribution of female surgical trainees now outweighs, at least maybe more in recent years, the male trainees. What's the distribution like if you have the granularity in the data between different surgical specialties? Because obviously things like gynae, obstetrics and gynae tends to be female dominated anyway, but certain specialties, for example, things like orthopedics, obviously have a reputation for being very male dominated. So
I don't have that specific breakdown, unfortunately. From the Royal College of Surgeons on the website, they probably do have the breakdown, but I can't remember it off the top of my head.
No.
We just looked at consultants as a whole in our quip.
Yeah, fair enough. And that can then lead us on, I guess, into neurosurgery specifically, which, again, this isn't based on anything, and it's maybe an inherent bias coming out, but I have the concept in my head that it tends to be more male dominated. Is that fair? Is that accurate?
Yeah, well, certainly in my experience, it has been more male dominated, but more and more these days, we are now appointing more female consultants, and there are a lot more female trainees and a lot more female registrars. But again, there is that bottleneck at the consultant level. So the thing is, without doing an actual study, I don't know if it's because of a gender bias or just a number thing. But there is a bottleneck at the consultant post where there just aren't enough consultant jobs. And I don't know if that equally affects males and females.
That's really important.
So that's something that I just don't know. But generally, most of the consultants are male, but I'm seeing a lot more female trainees coming up. And I do know a few female consultants. Like certainly at King's, we have 2 female consultants.
Good.
At Royal London, I think they have 1 at Queen Square. But yeah, a few are cropping up now.
And that's people, this is an area of interest for me, not just in surgery, but in the widening access to medicine stuff in general, in that I think people underestimate the power of having role models or having people that you can look at and think, that person is like me and is succeeding. You know, that... Yeah. I think that often gets swept under the rug a little bit.
Well, my neurosurgeon, as in my consultant for my neurosurgeon, is female, and like I really look up to her as well. And you know, she's successful. She has a family. She has children. Blah blah blah. Because obviously, that is quoted as a big barrier to women succeeding in neurosurgery. The fact that we become pregnant and we have to have the kids. So that's what a lot of perceived.
Inconsiderate, Gwen.
I know. Sorry, I mean, if you guys could have kids, that would be great as well. But sadly, we have to bear the burden.
I feel like our contraceptive products would be a lot better than they are if that was the case.
Yeah, exactly. But she's a big role model to me as well. And I've often asked her in our outpatient appointments, you know, can I do this? Is this going to hinder me in any way? And it's so empowering when she goes, Yes, you absolutely can do it. Like, don't put yourself down. Like, if you want it, go for it. And this is very different to my elective experience. Did I tell you about that?
Yeah, please do.
So for your viewers, an elective is when in med school you are encouraged to go and work or visit a different hospital to your own. And you can choose to stay within the same country, or you can go somewhere else. So I went to Vietnam for my elective, and I did it in neurosurgery. And day one, they were like, "Oh, you're a nursing student, aren't you?" And I was like, No, I'm a medical student. I'm going to be a doctor. And I was like, "Oh, okay, cool. And then by the end of the day, so you're just doing this for fun, right? You just want to see a few brains. You don't want to actually be a neurosurgeon, right?" And I was like, "No, I want to be a neurosurgeon. I'm very, very focused on being a neurosurgeon." And they went, "But you can't be a neurosurgeon." And I went, "Why not?" And they said, "Well, you're female. Females can't be neurosurgeons. Women can't be neurosurgeons." And I was like, What? And they said, "No, you're a woman. Women can't stand for long periods of time, and neurosurgery is very long." And I was like, okay, I'll prove you wrong. Cool.
Science.
I'm proud to say that by the end of that placement, they were like, "You're going to be a good neurosurgeon one day."
Nice.
Anyway, but yeah, we are making progress. There is still a long way to go. We are making progress, but unfortunately, we still do have just this inherent bias that exists not just in surgery, but in medicine as a whole. But hopefully, as we get more and more consultants, that bias is going to settle down.
Yeah. For what it's worth, those, again, wondering out there, I feel like neurosurgery, at least this is equally as someone who aspires to do it, but is much lower down the pathway into doing that, is that it's really helpful to acquire mentoring figures. Like Gwen has a consultant that she looks up to, and the closest thing that I've had to a consistent mentor has been one of the female trainees was working at my hospital, who, unlike any of the other male trainees who, I assume that in the rooms that I was in with the neurosurgeons, I used to go to the optional teaching and showing your face, and presumably was putting out the same enthusiasm, one would hope. It was only that female trainee that actually was like, let's work together, let's do something here. So you really get that support where you can, I think, for anyone, and that goes for medicine in general. Those of you at home, and accept it from anyone who is willing to give it. But it really, really helps if they look like you, or they feel like you, and you can identify with them, I guess. And that's, I think, one of the big hurdles. So let's have a look at some of these questions that people have sent in. There's not that many, but there were some really good ones. He says there are some really good ones. The first one from a Mr. Brandon Smith is, what's it like working with legends like us?
Legends like us.
Oh, Bran.
I don't really know what he's referring to, seeing as he never does any work.
Oh, shots. The sheer tea.
No, I am joking, Bran. You are awesome, and I appreciate you whenever you decide to do work. So thank you very much.
Yeah.
No, seriously, what does he mean by legends like us? Does he mean?
So I
like
think it's
a
reference to the fact that we all work as part of the Brain Book Collaborative.
Yeah.
Which you should all check out. It's a neurosurgical education collaborative, I guess.
We're a charity. We're a registered charity. We are the first, this is going to be my little brain book spiel, but we are the first UK charity dedicated to neurosurgery public engagement, neurosurgery education. So we aim to make neurosurgery just that little bit more accessible to patients, their family, anyone who's interested in brains, any little girl that wants to do neurosurgery, medical students, because it's not really covered that well in the curriculum, junior doctors, everyone really. We're trying to do a lot.
Yeah, that's really important to know as well. It hadn't occurred to me, but there are some specialties, sadly, of which neurosurgery is one, that is not covered under the kind of core medical undergraduate curriculum. There are a few like that. I found plastics to be like that. Ophthalmology is another one. They're never.
Dermatology.
Yeah, derm is another great example. You really, I think, usually have to go out of your way to be exposed to specialties like neurosurgery, which is a shame. But unfortunately, other than the emergencies, which, to be fair, as long as you can spot them, you don't really have to be able to do anything about them. You just have to, I guess, call the neurosurgeon when when the emergencies are happening, right? As a generalist or even a specialist doctor, I feel like most people's interactions with neurosurgery is not done in any real depth. No. Obviously I'm telling you what you know, just for the benefit of everyone at home. And then I think just that the other major one that we have here, which is quite a nice one to end on, and this can go both for being a doctor and I suppose for being a neurosurgery doctor specifically, is would you leave your job if you won the lottery tomorrow?
No, absolutely not.
There you go.
I mean, it would be nice to win the lottery, but no, I would be bored out of my mind. And I don't get the same sense of fulfillment from anything else apart from like my job. So, yeah.
Excellent. And then just
Sorry,
because you
really
mentioned
quick
it,
answer.
no, I think a quick answer like that, it conveys the enthusiasm, right? Like there was no deliberation, no nothing. But I'd be remiss to ask, just given that you mentioned it earlier, Gwen, what's your favourite video game?
Ooh, right.
Or your favourites. So, you can have 3, let's say.
Okay. So Skyrim is obviously a classic.
Still never played. I've still never played it.
Okay, your homework after this video is to go and play Skyrim. It is so good.
I do have actual homework, to be clear. Medical student life. But yeah.
Don't miss those days. Okay, Skyrim. I'm currently playing Fallout 4, which is long overdue, I know. If you have a Switch, Breath of the Wild is absolutely breathtaking. It is one of the very few games where I have not wanted it to end. It's incredible. What else is really fun? Satisfactory. I've started playing that. That's actually surprisingly fun as well. In terms of like other consoles, you can't beat a classic Pokemon game.
Which one? What's your top Pokemon game, Gwen?
Oh, okay. So I started on Gold because my parents never got me a video game console until I begged them, and they got me the Game Boy Advance. So I started on Gold, so that will always have a special place in my heart.
Yeah.
But Fire Red, the remake version of So Fire Red or Gold.
Oh, Gold is also my favourite. I think of all of them, the ones that I played. Excellent. What a wholesome way to finish off.
Show you my wholesome e-girl headphones.
Oh God, we were just talking about this.
Hang on.
The whole.
Yeah, there we go.
Can you model them for us very briefly? Are they lit up? Or are they?
Yeah, they light up.
Yeah,
they light up.
I thought I saw them. Yeah, changing colour.
Yeah.
Excellent. Kawaii. Kawaii as anything. I mean, I think if anything, Zoom.
I've been a paediatrician.
Yeah, everything being online.
Yeah.
Well, it's all brought into the realms of professional home setups and professional headphones and professional wear. Me and Gwen are both, I think, essentially wearing pajamas.
Well, underneath this.
Yeah, bottom half, the wonderful world of Zoom interviews. But that's almost on the hour mark, can you believe it, is where we'll wrap it of my recording. Yeah. So thank you so much for sitting down and talking to me tonight, Gwen.
Thank you for having me, and thank you to everybody for your patience with listening to my rambles about everything.
I think we've covered a lot of really interesting ground. Are you happy for people to contact you?
Oh yeah, absolutely, yeah.
Cool.
Just a small note. I am no longer working at King's. I have finished my contract there. I will be moving on to the Royal London Hospital, and I will be a neurosurgery educational fellow there. which means I will be dedicated to teaching. So it's
Is that not incredible? So anyone who goes to King's is applying to the Royal London even.
Oh no. This is my alumni mug. So if any of you are it's out of focus, but if any of you are going to King's, or if you have any questions about life at King's Medical School, more than happy to answer them. This is my repping GKT mug.
Gwen, disgusting. the London medical schools. Boo. But
nothing wrong. Oldest medical school in the world. True facts.
Fair enough. Consider me soundly put down. It's quite possible either way, whether you choose to go to a good medical school or you end up at King's, that you could be seeing Gwen as your educator. But please do get in contact with Gwen. I'm sure, particularly if you were in a similar situation to her, she'd be very happy to come sort you out. So thanks very much. That is where we will wrap. Thank you so much, Gwen. Have a good evening.
Thanks, Ollie. You too.